Hello and welcome. This is Robin Elliott with Parkinson Disease Foundation, and welcoming a near record for this series. I understand we have no fewer than 1,114 people tuning in from 16 countries and almost all of the 50 states of the United States of America. So we're delighted to have you for the session that we really haven't had before in this series. This is the fourth time we've run this series of expert briefings. And this one, we heard from many of our constituents, was something that people really wanted to know more about, namely the non-motor symptoms, and in particular, the under-recognized non-motor symptoms of Parkinson's disease. I want to thank, at the outset, and I'll do it again at the end, the companies that made this series possible by their financial support. One of them is AbbVie. It used to be Abbott Laboratories. AbbVie is its new name. Teva Neuroscience, and UCB, Inc. So we're very grateful to AbbVie, Teva, and UCB for making this series possible. Of course, as you will know, the editorial control is strictly independent and under the control of the PDF and its esteemed speakers. Be aware this is only one of the pieces of work that we do at PDF. If you want to know more and explore that, please visit our website, which is www.pdf.org. It's the shortest domain name in the business. And you can learn about anything else that we have to offer there, and give us a call if you have questions. I'm delighted to welcome today a very special guest, Professor Ray Chaudhuri, a very distinguished person in the field of neurology and in Parkinson's disease in particular. He's a professor in neurology and movement disorders and a consultant neurologist at King's College and the Institute of Psychiatry in London. An academic health sciences center, so you'll recognize a bit of my accent and his, but I can assure you that he's not related and is several levels above me when it comes to the intellectual and knowledge sphere of Parkinson's. He is an expert, among other things, in the continuous drug delivery treatment of Parkinson's and restless leg syndrome, in which he has a major reputation. He's also studied Parkinsonism in minority ethnic groups and sleep problems in Parkinson's. He's been the author of 215 papers, reviews, book chapters, and the co-editor of 4 books on Parkinson's disease and RLS. He's a public citizen, as are many of our speakers. I like to call them that, people who operate outside their scholarly parlors of the major universities and take part in major cross-disciplinary and intradisciplinary discussions of a policy nature. He's as part of the United Kingdom's Department of Health, the National Institute of Health Research. He has several roles there, also with the Movement Disorder Society, where he serves as co-chairman of the Appointments and Liaison Committee, and he's very active with the American Academy of Neurology, which, of course, is the largest neurology professional association in the world, and is meeting next week, and he's a very, very important contributor there. So we're very thrilled to have him, and we are very thrilled to have you, our audience and participants. And without further ado, I'd like to introduce, to speak to us today, Dr. Ray Chaudhuri.
Well, thank you very much for that introduction, and it's a great pleasure really to be able to address this audience, addressing an aspect of Parkinson's which is very close to our hearts here at the King's College Hospital Center, but I think one that could be translated down to Parkinson's across the world. And the area that I would like to speak on has been alluded to are the non-motor symptoms of Parkinson's, and specifically types of non-motor symptoms that are not recognized often in clinical practice and yet have a major role in the quality of life of people with Parkinson's and their carers. So if we move on to the setting the scene, so to speak, I think it's important to recognize now that our perception of Parkinson's has changed very considerably over the last 10 years or so. For instance, we now know that Parkinson's is not a condition that is only related to deficiency of the chemical dopamine, but it affects many other neurotransmitters, particularly serotonin, noradrenaline, acetylcholine, and so on. And here we have a recent paper from the well-known neuropathologist Kurt Ellinger, suggesting that this condition really should be considered as much a non-motor disorder as a motor disorder. So in fact, non-motor problems should be integral to the diagnosis and also to the understanding of what Parkinson's is, or as we understand it now. Now, this is, however, not very novel in many ways, because if we go back in the history, we look at the amazing work that James Parkinson, who obviously described the condition for the first time here in London, not far from where I am, he actually recognized many of these non-motor problems. In his essay, he writes that sleep disturbances, problems with bowels, constipation, dribbling of saliva, problems with swallowing, urinary problems, as well as sleepiness, and delirium, which presumably alludes to memory problems, were all recognized in his case series. So non-motor symptoms are not new. It was recognized by James Parkinson himself, but somehow the community at large has been a little sleepy about it, excuse the pun, of understanding these issues, and really it's only in the 21st century that non-motor symptoms have regained its prominence again, as it should, and research has developed our understanding of these problems of Parkinson's. So, firstly, let's consider when do these non-motor symptoms occur. Many of my colleagues believe, and there is a perception amongst neurologists generally, that non-motor symptoms are something which occurs late in the course of Parkinson's. In other words, after one has had the condition for 5, 6, 7 years or so. But this is actually not true. If we now look at the whole time span of Parkinson's, one would think that the whole condition might actually last for up to 40 to 50 years in some case. And in this particular slide, what you see is the clinical onset, which is in the middle. And that clinical onset is when someone with Parkinson's would typically come to the clinic to see us for a diagnosis, usually often with either with a small tremor on one side of the body, or difficulty in walking, or difficulty in speech, and etc. However, if you look to the left, you do see approximately a 20-year period during which other signs might actually be present, which might go on to predict the development of Parkinson's. And these signs are largely all non-motor. One of them is late-onset hyposmia, which is problems with sense of smell, which develops later on in lifespan. Similarly, severe constipation, sometimes major depression episodes. Now we know a sleep disorder called REM behavior disorder can all occur in the period which we now call the preclinical phase of Parkinson's, before even the motor symptoms are evident. And then, of course, non-motor symptoms are present throughout the patient's journey with this condition, from the very early disease to very advanced disease. And if we look at it a little bit more in detail, this is a recent piece of work which has again looked at this whole issue about redefining Parkinson's, and it would appear that we can probably divide Parkinson's now into 3 different distinct phases, there being a preclinical phase, which we think might be linked to specific genetic mutations, although this is very much in its early phase and by no means concrete. And then there is the premotor stage, or preclinical stage again, which is associated with these non-motor problems, loss of sense of smell or reduced sense of smell, which develops later on in life, problems with constipation in particular, REM behavior disorder, which is a sleep disorder when somebody acts out violent dreams, severe daytime sleepiness, in some situations fatigue, major depression, and also pain often occurring on one side of the body, which might lead to misdiagnosis in some cases, and patients, for instance, might be referred to a rheumatologist first when the condition is actually Parkinson's. So this again highlights the importance of non-motor problems in the very early stage of Parkinson's. Interestingly, we worked on this area and developed the first ever validated questionnaire for non-motor symptoms in Parkinson's, but that only happened in 2006. And before that, there were no such questionnaires which have been specifically validated for Parkinson's. This is something we now routinely use. It asks 30 questions, and people with Parkinson's usually complete this while they're waiting to be seen. So as soon as I see them, I have a snapshot view of their motor and non-motor picture. As a result, for instance, yesterday I saw a patient who has been managed very well for his tremor and his rigidity. However, the non-motor questionnaire, the patient declared there were problems with dribbling of saliva, there were problems with depression, there was problems with also insomnia, restless legs, and also problems with swallowing difficulty. Now, these can all be addressed and managed in the clinic, but were never managed before because the doctor or the nurse hadn't specifically addressed these non-motor symptoms before. And that's the role of the non-motor questionnaire that we currently have. In addition to the questionnaire, we can also use the scale. Now, this has been again specifically validated for Parkinson and has been used around the world, and this addresses 9 different domains, 30 questions like the questionnaire, but unlike the questionnaire, it's the doctor or the nurse who would administer the scale, and this allows you to measure. So in other words, if I treat somebody for, let's say, dribbling of saliva, then the scale can measure the score of this problem before treatment, and then when the patient comes back, we do the measurements again to see whether the treatment has worked or not. And I'm happy to say many of the recent studies by pharmaceutical companies are all using the non-motor scale as an outcome measure, and this is highly important because just measuring motor symptoms alone is no longer adequate in the management of people with Parkinson's. Moving on, what did these studies first tell us? Well, the first thing we did with the questionnaire was look at a group of people with Parkinson's across the world and then an age-matched control group who didn't have Parkinson's, so a healthy control. And in this slide, you'll see that Parkinson's patients had highly significantly more non-motor symptoms as a whole compared to matched controls. Further studies have now shown that on average, any Parkinson patient will have at least 4 to 6 different non-motor problems. That is the nature of importance of this particular issue, and that is why it must be assessed and needs to be assessed in the clinic on a regular basis. A further set of work was then done across Europe, and that's been identified in this paper that's highlighted here. Here, we looked at the people who have ticked yes in the non-motor questionnaire. So let's say they said 6 different non-motor problems were present. We then went back and asked them, have you ever discussed these symptoms with your doctor and your nurses? Unfortunately, in over 50% of cases, non-motor symptoms were never discussed with their doctors or the nurses, even though the patients have been coming to the clinic in some situation for up to 10 years. And the impact of this, in this right side, you'll see the 30 different non-motor symptoms, and you see the non-declared symptoms. So, for instance, right up top is dribbling, and you can see 46.5% of patients studied had never discussed their problems with dribbling with their doctors. And if we look at this further, in this particular slide, on the right, you see the different NMS, which are the non-motor symptoms. So you have dribbling of saliva, vomiting, constipation, hallucination, anxiety, daytime sleepiness, REM behavior disorder, which is the sleep disorder, and insomnia. You see the percentage undeclared, in other words, 45% dribbling of saliva never declared. In over 52%, daytime sleepiness, people falling asleep during the day, either while having a meal, sometimes driving, were never discussed. And these are all treatable issues. And these symptoms were only treated after the non-motor questionnaire was administered. Once again, shows 2 things. One, that the medical community at large is still not fully aware of the impact and the need for assessment of non-motor symptoms. And as a result, many of our patients are still not getting adequate treatment for non-motor symptoms, and this is not one. As I said in the questionnaire, there are at least 30 different ones we've tried to address in the questionnaire and the scale. Another area that has been particularly poor, we've been poor in understanding, is what we call non-motor fluctuations. Now, many of you will be familiar with the concept of motor fluctuations. So this is somebody has Parkinson's, takes a tablet of levodopa, perhaps it works for a few hours very nicely, and then the effects wear off, the tremors comes back, the stiffness comes back, and you know you need to take another tablet. So it's so-called on and off fluctuations. We now know that these fluctuations can also be associated with major non-motor problems. And in a recent paper, we have shown that several non-motor problems, which are shown in these slides, such as fatigue, pain, dribbling of saliva, sexual disturbances, disturbances of vision, autonomic problems, particularly excessive sweating, can all be part of non-motor fluctuations. So in other words, if you use a treatment strategy that can reduce the fluctuations, they will also have a beneficial effect on many of these non-motor problems which remain unexplored and underreported still. So non-motor fluctuation would be another important area, and I think there's far more research that needs to be done in this area in future. Now I'm going to just focus on a few specific non-motor issues and ones that we think are particularly important and often not discussed. Now the first thing is fatigue. Fatigue is a very widely used term and often not properly understood. Fatigue means a sense of intense and sometimes very exhausting sense of exhaustion. So people feel incredibly drained and tired. And this is quite different to feeling sleepy. The two are quite different. We now know that people with Parkinson's have a condition very similar to people who get the so-called chronic fatigue syndrome. This might occur even if there's no depression, there is no excessive daytime sleepiness. This might occur independent of any intake of dopamine drugs. So fatigue is therefore a major issue in Parkinson's, and we're still to find out what exactly leads to the problems of fatigue in Parkinson's. We know, however, some treatments can help with fatigue that this slide, for instance, shows in the second column. In blue, the large blue bar going downwards shows a beneficial effect on fatigue with the active drug compared to the placebo, which is in gray. So this shows, for instance, that this particular drug, in this case retigotine patch, has been shown to have a beneficial effect on fatigue in Parkinson's compared to placebo, which appears to have no effect in Parkinson's. It's really worth pointing it out at this stage that many colleagues would believe that fatigue is a problem that might occur later on in Parkinson's. That is actually not true. Fatigue is now been shown to occur in up to 37 to 40% of people who present to the neurologist for the first time. And then the prevalence figures slowly rise. So once again, unless you're specifically asked about it, unless it's specifically discussed, treatment and management of fatigue remains suboptimal. And as you can see, some treatment strategies are already available for this disabling problem. So if we can highlight, therefore, the issues around fatigue, it's important to remember that fatigue is different to excessive sleepiness. Fatigue is different to depression. Fatigue can occur throughout the course of Parkinson's. So very early Parkinson's, a very advanced disease. It can be very disabling in some people, where that can be their major problem. I've had patients tell me, I'm not too bothered about my tremor, I'm not too bothered about my stiffness as such, but do something about this tiredness, this constant feeling of that I can't do anything, which really stops me from being social and causes me to be isolated. Fatigue can be independent from depression, from sleepiness, and from your motor disability. So in other words, you can have very minor motor problem, maybe just a little bit of tremor on one side, or might be just a difficulty of writing. On the other hand, you might have quite major degree of fatigue. We also now know that fatigue can be a major issue with quality of life. So in other words, quality of life of the patient and the carer can both be affected adversely by severe fatigue. And we also now know from imaging work that we've done here in King's with colleagues at Imperial College that it's the deficiency of serotonin in the brain which is a different neurochemical to dopamine, that can actually be possibly causing these fatigue-related problems in Parkinson's. And therein lies our biggest challenge. We are all focused on dopamine treatment of Parkinson's when we know so much of non-motor problems of Parkinson's comes from the non-dopamine side, in this case serotonin, for instance. Moving on, I would like to just say a few words about pain. Pain is another big problem of Parkinson's. In a minute I'll show you the prevalence figures of it, but for many, many years pain has remained underappreciated in Parkinson's, partly because many people think, oh, well, Parkinson's can occur largely in the older age group, and in this age group pain is very common anyway, from either arthritis or difficulty with mobility, etc. There's also been a problem, as it says in this slide, with definition of pain, whether the pain is related to a specific area of the body, nociceptive, or is it more related to the nerves, neuropathic, other confounders such as arthritis, normal pain that aging would cause, and is there a concept, what is the pure pain of Parkinson's? Well, we now know that prevalence has been established in pain in many studies. And here I put up a table from a study called the Priamo study, which was performed in 2009 across Italy. And this study looked at over 1,000 patients. And if you look at the blue circled column or row, you see pain, and you see overall 60.9, so 61% of 1,000 patients, over 1,000 patients, complained of pain. In the first column, you see Hoehn-Yahr stage 1, so these patients are very early motor Parkinson's, but even at that stage, 51% have pain. And if we go to further up, in other words, stage 4 and 5 of Parkinson's, advanced Parkinson's, almost 80% complain of pain. It is so crucially important, but again, if we went back to the study that I showed you, we found that in over 40% of patients, pain has never been discussed in its entirety, and as such, pain has not been treated in many patients. We have been trying to look at this by looking at a thing called pain scale, and the PD pain scale will try and address pain of Parkinson's in various different ways. We've identified different types of pain in Parkinson's. For instance, as you can see in the scale, there is musculoskeletal pain. This is pain arising from a joint or a muscle area. There is chronic pain. This is pain. Many patients describe to us pain that is a deep internal pain, as if it's arising from the stomach or from the bladder or from the liver, that sort of area. Then there is fluctuation-related pain. Many people get pain as the drug is wearing off, and they need to take a dopamine drug to help with the pain. So that's dopamine-sensitive pain. Then there is another few types of pain that's addressed in the scale, nocturnal pain. Some people with Parkinson's get pain typically at night. This is often related to difficulty turning in bed, for instance, or getting up first thing in the morning. One might be very stiff. One might have pain, particularly around the shoulder muscles or on the back area. So we call it nighttime pain. Then there is a variant of orofacial pain. People get pain around the face, particularly around the teeth, because you can grind your teeth at night, a condition we call bruxism. Some people get another condition called burning mouth syndrome, where the mouth is like as if it's on fire. And we know again that this is typically related to Parkinson, as it really got nothing to do with the teeth. The other thing is, in Parkinson's, gum problems are common, and teeth issues can also relate to local pain. So orofacial pain is very common. And then the other two types of pain are pain related to edema. So edema means swelling, and this is often related to dopamine drugs. People might develop an ankle swelling on one side or a leg swelling, which can become quite painful at times, and one needs to address that by alteration of medication. And finally, radicular pain. Radicular pain means pain that shoots down the body. So it can go down from the neck down an arm, spine down to the legs, etc. Anything that travels, we would call that radicular pain. So we are in the process now of trying to validate this pain scale, which will be the first one of its kind. How do you manage pain in Parkinson's? It's a very complex problem. One had to address the comorbidities. In other words, is there any other painful conditions that's going on, such as fibromyalgia? If the pain is related to wearing off, in other words, it's related to when the drug's wearing off, we use longer-acting agents. So, for instance, in the UK, we use apomorphine infusion in this situation, or the retigatin patch, or longer-acting drugs, which reduce the fluctuations. But if the pain is neuropathic, if the pain is musculoskeletal, or pain related to dyskinesias, you might have to use different management strategies, and therefore a specialist clinic which has an expertise in pain is of particular importance in this area. Staying with the other underappreciated non-motor issues, I'd just like to highlight the issue about swallowing and dribbling of saliva. Now, in this slide, we see that, as it says, hurdles en route from mouth to the brain. Every time somebody takes a tablet in Parkinson's, the tablet is given several levels of resistance before it gets into the brain. One of the levels of resistance is swallowing. The second one is in the stomach, where there is a barrier to its absorption. The third one occurs in the blood, and then in the blood-brain barrier, and finally in the brain itself. So all these barriers have to be overcome, but if you're using a tablet in the oral route. Now, there has been some studies, and this is our own study in 2006, where we looked at the 30 different non-motor problems, which are listed in white at the bottom of your slide. I won't go through all of them, but the first three are of interest. The first one talks about dribbling. The second one talks about taste sensation. So how well do you taste food, for instance? And the third one talks about swallowing. In yellow are people with Parkinson's, and in blue are age-matched controls. So if we look at swallowing, we find that our Parkinson patients had 28% complained of problems with swallowing, while 4% only in the healthy control. If we look at dribbling, the figures rise quite a lot more. 40% of people with Parkinson's had problem with dribbling of saliva, and the two are linked. In Parkinson's, people have dribbling because of swallowing problems, because the saliva pools in the mouth. And again, I don't think this is properly appreciated and managed in many situations. This is a European survey. When patients were asked, on average, we found they were taking up to 19 different tablets. 60% were due to Parkinson's, and 40% were due to other conditions. And when these patients were then asked, do you have a problem with swallowing? 59% of these patients said yes. And you can understand in such a situation, giving more tablets will be even more troublesome for the patient. And here, for example, is shown a patient with Parkinson's whose stomach is filled with so many different tablets at a fixed time, because people are often taking medication for high blood pressure, for cholesterol, for diabetes sometimes, etc. So this is worth remembering again, that swallowing difficulty might actually need to be voiced, and you need assessment with speech and language therapist. In many situations now we have access to management of Parkinson's using treatment avoiding the oral route. In other words, either using a skin patch or injection treatment similar to perhaps insulin in diabetes. Another problem with dribbling and with swallowing difficulty is silent aspiration. Silent aspiration means silently swallowing some of the sputum and saliva without actually being aware of it. And this is very common in Parkinson's. And this study, which was performed in Sweden in the late 90s, showed in their study that 40% of their patient population were having silent aspirations without them being aware of it. This was shown by a technique called video fluoroscopy. And importantly, it's worth noting that if you have silent aspiration, you're more likely to get chest infection. And again, so the link, therefore, with swallowing difficulties, dribbling of saliva, and chest infection, and one that can be easily managed and easily prevented, provided it's voiced and provided it's managed in the clinic. What about two other problems I wanted to touch base on? One is excessive sweating. Excessive sweating is again a part of Parkinson. It's the third last column in our study. You can see here where the yellow mark shows Parkinson's patient, in blue the controls. Excessive sweating was twice as common in Parkinson's compared to control group. This excessive sweating typically occurs in two stages. One often occurs at night. People wake up with drenching sleep sweats. And the other one can occur during off periods. So as the drug wears off, you get anxious, some people get panic attacks, and along with this comes this sweating attack. The other one that we've been particularly looking at is double vision. Many people with Parkinson's experience fleeting double vision. As you can see, this is listed in the last but one column. Highly prevalent in Parkinson's, figures were about 20% compared to virtually nothing in the controls. Now, the cause of double vision Parkinson's is not very clear. Sometimes it might be a manifestation of visual hallucinations, but in many other situations it is actually due to the muscles of the eyes not working properly. So truly speaking, you might argue it's not a non-motor feature, but that final outcome, which is the double vision, is indeed a non-motor issue. What about other specific problems? Well, as we've discussed, that swallowing issues might be a big problem in Parkinson's, and can we do anything about it? Well, there are 4 strategies that can be used in situations where swallowing is a problem and there's marked dribbling of saliva. Commonest one we use would be the rotating patch, which is a skin patch. In the UK and Europe, we would use apomorphine infusion. I understand apomorphine injection is now available in the US. Apomorphine infusion is given very similar to the way insulin is given for diabetes, by a simple, tiny injection, and a pump drives it. In many other patients, you might be able to use deep brain stimulation. You'll be familiar with that. And also, more recently, we've been also using the levodopa infusion therapy, whereby using this pump, we can put the gel formulation of levodopa straight into the jejunum, which is the lower part of the stomach, and it gets absorbed straight from there. The baseline for all these therapies is that it avoids the problems of oral treatment in situations, and particularly relevant in situations where you've got problems with swallowing and dribbling of saliva. Staying on with the issues again, we also have to be aware of the side effect profile of many drugs, and one that's come up of late of concern is the so-called impulse control disorder. This might take the form of compulsive gambling or hypersexuality or compulsive shopping or compulsive use of internet and so on. We think it's linked to use of dopamine agonist. A large study by Professor Daniel Weintraub in the U.S. Showed that this is very prevalent in Parkinson's, up to 16%, and it might be linked to dopamine agonist treatment, but it's worth noting that even levodopa in early high doses can cause some of these problems, and in fact one can obtain levodopa over the internet as an aphrodisiac. So this is something we need to be aware of, and particularly in our advice giving to patients with the treatment of Parkinson's, because on one side there is nothing one can do, that you have to have management with dopamine therapy. On the other side, we need to be aware of the problems of this therapy, and monitoring is very, very important, and this is again really another non-motor side effect of current therapy. Staying with non-motor side effect, another problem that has recently come up is the so-called dopamine agonist withdrawal syndrome, or DAWS. 3 papers have now appeared suggesting a rate of anything up to 15 to 20%. We are now doing a large study across Europe to look at this particular problem. Now, what is DAWS? DAWS means it's a withdrawal syndrome, that if somebody comes off dopamine drugs, particularly dopamine agonists, so if your doctor or nurse suddenly stops one of the dopamine agonist drugs, people often develop this condition when they have very high levels of anxiety. You get panic attacks. There's dysphoria, so you might feel quite depressed, down, and the mood might particularly be down. There is often pain, and there might be sweating attacks. Now, this particular problem can last for a long time, and the real management of this is reintroduction of the dopamine agonist at a very small dose. But the neurologists and the nurses need to be aware of this, because DAWS is often very poorly recognized in clinical practice, And in some ways, actually, it has a similarity to withdrawal symptoms that people might get, those if somebody, for instance, might be addicted to an agent such as cocaine. So some aspects of dose are similar to withdrawal from any sort of addictive drug. So dose is another aspect of the non-motor side effect spectrum of dopaminergic drugs. Now I'm coming towards the end of my talk, and I wanted to really address another issue that we've been particularly working on. I think the message that I wanted to really say is that it's critically and crucially important that non-motor symptoms as a whole are routinely inquired of and asked about in the clinic. Just asking one or two specific non-motor symptoms, such as are you depressed, do you have problems with sleep, is simply not adequate in the modern management. And what we have proposed, this is hot off the press, and is currently, this paper is in press, is a new way of grading Parkinson's, which takes into account not just motor, but also non-motor. Currently, the standard way of grading Parkinson's is by a technique called Horn-and-Yahr staging, HNY, which only addresses motor symptoms. Is your condition on one side? Is it both sides? Is there a problem with balance? And so on. But what we're saying is that if you use the non-motor scale, which I showed you, you can grade people from stage 0 here, which is no non-motor symptoms, to stage 4, where you score over 70, we would say it's stage 4, which is very severe non-motor staging. Interestingly, we find that many patients might have very early motor disease, so HNY stage 1 maybe, but they might be non-motor stage 3 or 4. These patients would need very different treatment strategies to another person who might have similar degree of motor and non-motor problems. And hence, I hope that this particular concept is taken up and colleagues start using these assessments as a routine at least once a year in the clinic. So what would be the modern concept of assessing somebody with Parkinson's in clinic? Firstly, motor assessment alone is inadequate and old-fashioned. We must take into account non-motor symptoms. Why? Because it is the biggest determinant of quality of life. We have to think about direct non-motor problems and indirect non-motor problems, such as diplopia, such as non-motor side effects of treatment, for instance. We can now stage very easily using the Horn-and-Yahr stage, which has been there since the 1960s, and the new non-motor staging that we've just proposed, which has been published. On the whole, if we do this, I think management will improve, quality of life will improve, not just of the patient, but also the carer, and we will have no further talks where we will perhaps be talking about non-motor symptoms that are ignored. In other words, we will make sure that these symptoms are not ignored or not discussed in future. Many reasons for non-motor symptoms being underexplored and not being talked about properly is the lack of awareness, particularly in the medical community, about non-motor symptoms. So to summarize, how can we summarize what I generally touched upon today? Well, firstly, non-motor symptoms are crucially important in Parkinson's. Contrary to what many people believe, it occurs before the motor problems of Parkinson's start and stays throughout Parkinson's. We have shown in many studies now that it is the biggest determinant of quality of life of people with Parkinson's. We have also suggested and shown that, contrary to what many people believe, that it is treatable. However, it's important to recognize that Parkinson's is not just a single neurochemical disorder. For instance, fatigue and serotonin, so one size doesn't fit all. And only after you've done an assessment of motor and non-motor staging, you can then take a decision as to how treatment will be offered. It continues to be under-recognized, as our study shows, and I think with time, with more awareness, talks like this, hopefully it will help the doctors and the nurses to address this more often. We need to address this as a holistic measure, in other words, not just take one or two non-motor symptoms, but look at it as a whole, because the person who comes with Parkinson's in front of me presents with all of this. We can't just pick out one or two bits and ignore the rest. Obviously, we need much, much more money and research into what's causing these problems. Only when we know that we can devise proper and correct treatment for these symptoms. And finally, our pharmaceutical industry needs to be more proactive in ensuring that their clinical trials use non-motor endpoints in studies. And I'm very happy to see that for the first time, the RECOVER study, which looked at radiating patch, for instance, several other studies, another one called Cleopatra, have all used non-motor scales now as an endpoint. Therefore, looking at their treatment, whatever they're using, how effective is on motor, but also how effective is on non-motor symptoms. And I think that sort of is a summary of where we are with this very important issue with Parkinson's, particularly non-motor issues. I presented a large body of research from our group, and this picture really shows many people that I have to thank, particularly our close cooperation with many opinion leaders across Europe, in the US, in Japan, and parts of Asia. Here we have our own research group here at King's, and also here doing one of our non-motor research meetings. We also have a very active patient group called CRISP, who we meet every 3 months and who advises us on new research. For instance, CRISP is the group that helped us develop the pain scale for Parkinson's. And in future, we hope that we'll be doing more work with our people with Parkinson's and empower them to tell us more about these non-motor symptoms. And hopefully, we will have good treatment, good evidence base for treatment, and good awareness of this problem in the next few years. So I thank you very much for your attention, and I hope that was of some help.
Thank you, Dr. Chaudhuri. Just outstanding. This has really been a wonderful, wonderful talk. Believe it or not, audience members, we actually had to ask poor Dr. Chaudhuri to drop about 20 or 25 of his slides because there was so much to be said, and you wouldn't know it from the richness of the presentation. But there is a lot to be said about this, and certainly Dr. Chaudhuri has his hands on the really important stuff. So we're terribly grateful to him for this. I want to just remind you, for those of you who still wish to text us a message, that is a text messaging feature built into the lower left corner of your viewer page. You click on the box below, enter your question, and then click on the send button. We are already 3/4 of the way through our allotted hour, so we may not be able to answer all your questions during the session, but you can be sure that we will do it afterwards and with Dr. Chaudhuri's help and get back to you. So do keep the questions coming if you wish. Given that we have so many and such a terrific talk, I am going to ask your forbearance and Dr. Chaudhuri's, if he has the time, we shouldn't assume that, to go 10 minutes beyond our normal appointed hour, which means we have 20-25 minutes worth for some of the questions. And so without further ado, let's move to those. Dr. Chaudhuri, I was trying to follow the slides as you were listing all those symptoms, and then matching those against questions that had come in from people who said, is this a symptom? Is this a symptom? Is this a non-motor symptom of Parkinson's? And there are about 5 or 6 of those that I believe you didn't mention, and so I would like to have, if it's okay, a kind of a rapid-fire thing. Sure. I will mention that the symptom that's been suggested, and you will say it is, or it isn't, and any other comments you'd care to make. So if you may do it, I think we have half a dozen to go through. First of all, from Virginia, United States, is vertigo a non-motor symptom of Parkinson's?
It's not a specific non-motor symptom, no.
Mm-hmm. Second,
but it can be it can be indirectly related. So, for instance, vertigo can be linked with dopaminergic drugs that people take. So we can't exclude it completely, but I wouldn't call it a direct non-motor symptom of Parkinson's.
Thank you. The second one, we know that there's a connection, very different connection with melanoma and Parkinson's. Is this considered a non-motor symptom, however rare? Is melanoma considered a non-motor symptom of Parkinson's?
No.
It is not. Third, stuttering. Is stuttering a non-motor symptom of Parkinson's?
It's not. It actually would be classed within the motor symptomatology because it's very much a problem with articulation.
I should have thought of that. That was my fault. Forgive me. Fourth one, chronic skin irritation. Somebody asks from Colorado. Is that considered an accompaniment to Parkinson's and a symptom of it?
Yes, and again, this might be linked to the issue of hyperhidrosis, which is excessive sweating.
Mm-hmm. Thank you. Here's a question from Ohio, and the person wants to know, I think actually you did mention this, so I should apologize again. A significant drop in blood pressure. How is that considered a non-motor symptom of Parkinson's?
Yes, very much so. It's part of what we call the autonomic problem, and the specific condition called postural hypotension. So yes, it is part and parcel of the non-motor spectrum.
Okay. And now we have a couple which are more in the sort of cognitive area, I guess you call them. From Pennsylvania, somebody wants to know if it makes it more difficult to make decisions when you have Parkinson's, I guess a form of executive function. And from North Carolina, we have somebody who says that she has a word in her head, but it doesn't always come out that way. Both the word in the head problem and the decision-making problem, are these considered non-motor symptoms of Parkinson's?
I think they both are. I mean, essentially, the first problem, which is executive decision-making, we know is impaired in Parkinson's. In fact, right from the beginning, and some people would call this the so-called MCI, or a minor sort of minimal cognitive impairment. It's also known in Parkinson's, for instance, bimanual tasking is very difficult. So normally we would often multitask, or you can multitask, but multitasking in Parkinson's becomes very difficult because, again, that activates the same pathway as the executive decision-making. In terms of the speech coming to mind but not being able to express, that's a so-called expressive difficulty, again, is sort of related to this whole circuitry and pathway, and yes, very much part of the cognitive aspect of non-motor symptoms.
Thank you. And finally, in this list of symptoms people are asking, are they connected with Parkinson's, the matter of confusion. If you're confused, again, maybe a cognitive question, maybe related to that, would this be considered a symptom of Parkinson's?
Yes, very much so. In fact, in our non-motor questionnaire, the last item is delirium, and that sort of addresses confusional episodes in Parkinson's. Again, the cause of this might be a range of reasons. For instance, it could be related to drugs, or more often it could be related to an underlying infection, such as chest infection or infection in the waterworks, can trigger an episode of confusion in Parkinson's.
Thank you. Now shifting to different matters, one symptom or set of symptoms that you did discuss at some length, but we had lots of questions about them, so I'm going to reintroduce it because you may have a bit more to say, is the matter of digestion, bowel problems, and related matters. Yes. There's a person from Latrobe in Pennsylvania who wants to know how common this is in Parkinson's. I think you may have mentioned this, but I didn't make a note of it. And the second from Ohio, there's a question as to whether what kinds of solutions are there. You did allude to that, but since there are so many questions of that nature, perhaps, Dr. Chaudhuri, you could spend just a little more talking about what are the most common aspects of the digestive constipation-related problems in Parkinson's, and you already certainly said that these are treatable, maybe very well treatable, but you might want to speak a little more about how they're treated.
Okay, I mean, yes, this was in one of the slides where we showed the prevalence figures of various different non-motor symptoms. And in fact, it really addresses not just one symptom, but many, which would be referable to the digestive and the bowel system symptoms. So going from top downwards, for instance, swallowing problem, then often people with Parkinson's might have nausea as well as vomiting. And then there is the problem of, I'm just looking at my slides, constipation, and then a bowel incontinence can occur, as well as, and then going into the incontinence of, or a sense of incomplete evacuation of bowels. All of these can occur, and they range from anything between 30 to 60%, so they're pretty prevalent. The one that's probably most common in Parkinson's in terms of the bowel disorders or digestive disorder would be, apart from the dribbling of saliva, would be constipation. And again, this is caused by various different problems, diet, as well as involvement of the autonomic nerves, as well as the movement of the bowels, and so on. So really a range of problems. And in many ways, when somebody's got major problems with these digestive symptoms, one should really look at alternative ways of treating Parkinson's, in other words, non-oral therapies. So one aspect of the treatment is using dopamine drugs, but not using the oral route, so you can either have the patch or injections and so on. And then address specific problems. So, for instance, if constipation is a problem, then you might have to use specific types of laxatives, which can either soften the stool or increase the bowel movement. If the problem is with dribbling of saliva, which is a huge issue in many people, often we have to use a range of treatment here. For instance, what works really well is a mixture of assessment by a speech and language therapist who would often advise on improving posture of the neck by using a swallow timer. So there's a timer that ticks and it reminds the person to swallow regularly so that the sputum doesn't build up. And in addition, sometimes putting in a few atropine drops in the mouth, which can dry up the secretions quite effectively. So, you can sort of take different strategies, but by far those two are the commonest, so those would be the ways to address it. So one, you address the specific symptoms, and also you try and use a non-oral form of treatment.
Wonderful. Thank you very, very much. We have two questions on pain. You spent some time discussing the pain syndromes in Parkinson's, but these are two aspects of the question that I think were not brought out completely, so I'll try them out on you, Dr. Chaudhuri. Yep. First of all, from New York City, can Parkinson's, in some cases, actually prevent the perception of pain? We had a story, which I just read off one of our text messages, about somebody a very elaborate story, in which the person who had a condition that normally would cause pain didn't feel anything, and he was wondering whether this could be that the Parkinson's could actually depress the pain feeling.
It's a very interesting question. There have been quite a few studies on the perception of pain in Parkinson's. What we now know is through brain MRI studies, functional MRI studies, and also from skin biopsy studies, that the perception of pain in Parkinson's actually goes up. So skin becomes very sensitive, or the person becomes very sensitive to pain when somebody's in an off state. So as the drug wears off, the perception of pain is really quite high. On the other hand, when somebody's condition is relatively well controlled, and when the dopaminergic drugs are working well, and the person is on or on-off fluctuations hasn't started, the pain perception appears to be, in other words, people might be relatively insensitive to pain at that stage. So it seems to be a state-dependent effect in many ways, in particular heightened pain perception during the off state.
Good, thank you. And the second pain question, which is from St. Louis in Missouri, is a person is asking, who followed very carefully your commentary on pain and Parkinson's, but he was wondering, since there are other sources of pain, and he cites arthritis as a particular example of this, how can one tell whether it's arthritis-related or Parkinson's-related?
Yes, this is a very frequently asked question, and in fact, this is a good one, but one that can be quite misleading. There's a general perception in many of my colleagues that if a person with Parkinson's comes and says, "Oh, I've got pain in my knee joint," for instance, the automatic perception will be that this might be something to do with arthritis in the knee. And there might, in fact, be arthritis in the knee. But the fact of the matter is that many of these patients, once the treatment has been attempted, in particular with dopamine treatment of any form, suddenly the first thing the patient will say, actually my knee pain has disappeared. I've got a few videos of people where they have been told for years that they've got arthritic joint pain, and then when they went on, for instance, levodopa infusion, one patient, her joint pain completely disappeared. So there are two types of joint-related pains in Parkinson's. I didn't really have time to go into the individual details. One we call indirectly aggravated. So in this situation, the pain in the joint is actually sensitive to dopaminergic drugs, and in that case, the pain in the joints is actually related to Parkinson's. And in another group, the pain is there regardless of whether they're on dopaminergic drugs or not. It's specifically in the joint, the clear indicators of joint-related arthritic problems, where would say that, okay, this is arthritic pain or Parkinson's.
Very good. Thank you so much. We already talked about, quoted some questions from people who were asking whether this or that symptom is in fact a symptom of Parkinson's. Now I have a similar set of questions, a shorter one, from people who are asking about therapies, Dr. Chaudhuri, and three in particular. Is this a therapy for non-motor symptoms in Parkinson's, or is it not? From Ohio, somebody said she read that this advanced combination of antioxidants could have an effect on non-motor symptom in Parkinson's. Is that true?
I don't think there is any specific, robust, evidence to suggest that antioxidants help non-motor symptoms of Parkinson's. The problem is, which non-motor symptom are you talking of? As I explained, that is a huge range of non-motor problems that occur in Parkinson's. So you've got to be more specific as to which particular one is talking about. There is some evidence that antioxidants might be helpful in the overall neuroprotective side of Parkinson's, although we don't have any formal proof of that. If that is the case, they might help some of the preclinical non-motor problems, such as sense of smell, for instance, or even this sleep disorder called REM behavior disorder. But really, the evidence for that is very, very weak at the moment.
Thank you. From San Diego, another question about potential therapy. This person would like to know whether neurofeedback therapy, or biofeedback, can that address both the motor and the non-motor symptoms of Parkinson's?
Yes, I think it can. And again, we need to look more at also non-drug therapies in Parkinson's. And biofeedback, then other issues such as cognitive behavioral therapies, as well as forms of physiotherapy can all be beneficial for some non-motor problems in Parkinson's.
Thank you. And the third question about therapy from Colorado, a correspondent asks Dr. Chaudhuri, to what extent could non-motor symptoms, or some of the non-motor symptoms, be ameliorated by deep brain stimulation surgery?
Yeah, there is, to be honest, deep brain stimulation has really focused on motor symptoms, and it has focused on quality of life as attributable to the motor symptoms. So far, there's been no systematic studies of non-motor effect of deep brain stimulation, in spite of huge advances being made with this procedure, partly because the clinicians have been really focused on motor symptoms, as I've said in my talk. However, there is now emerging evidence that DBS might be particularly good for some aspects of sleep in Parkinson's, and is also very effective for Parkinson's-related pain. But we need to really do proper studies using scales such as non-motor scales in people undergoing DBS, before DBS and after DBS. And in fact, we are currently doing such a study across several centers in Europe.
Great, thank you very much. So just to round up a couple of questions. First of all, I'm going to out this person because I know her. And if anyone had a PhD in Parkinson's, it would be this woman from Tennessee. It's a good friend of ours. Her name is Peggy Willocks. She obviously doesn't think that Dr. Chaudhuri has worked quite hard enough in the last hour, so she's asking her PhD kind of question. Dr. Chaudhuri, because of the potential effect of non-motor symptoms on motor symptoms, what about a holistic approach, a research model that actually studies the potential impact of one set upon the other set?
Yes, I mean, I think that would be the ideal scenario, but the problem is now we have yet not got to grips with the underlying pathophysiology of non-motor problems properly. We need to understand that first before we can address holistic problems, holistic models. We don't know, for instance, where fatigue really arises from. We don't know, for instance, what is the underlying nature for excessive daytime sleepiness in Parkinson's. We don't know, for instance, exactly where or how the autonomic problems have been done, because nobody's done these studies in a proper, systematic manner. And I think that's the first thing we need to do. And then, of course, yes, I think a holistic model looking at the individual effect of one group of symptoms on the other, in other words, non-motor and motor, would be really quite interesting to do.
Great. Thank you. Another question just came in, which I want to pop into the deck before we close. This is an interesting question that relates to the symptoms that you described in an earlier slide, where you trace the 4 or 5 years before motor symptoms and then the years afterwards, and how the non-motor symptoms often come earlier. This particular question, though, is another facet of the same problem. A person from New Jersey wants to know. If for a person who is young onset Parkinson's, as opposed to more traditional onset in early 60s or mid 60s, is there any difference between those two groups in the pattern of non-motor symptoms versus motor symptoms, either in the extent to which they occur or in the phasing?
Yeah, it's an excellent question. And in fact, we have done some work on it. And in fact, very recently, a paper has been also published on differences between young onset and late onset Parkinson's and non-motor problems, and the broad pattern seems similar, but some non-motor problems such as pain and in fact fatigue and also issues like impulse control disorders appear to be commoner in the younger onset people with Parkinson's compared to the late onset Parkinson's.
Very interesting. Well, this is just terrific. I have one final question, which is a it has some tongue-in-cheek, but also, as a good tongue-in-cheek point always is, it has a strong element of seriousness. A friend of ours from Alaska is very interested in what we're doing to educate the rest of the medical community in the non-motor symptom issue that Dr. Chaudhuri takes for granted, but many of his colleagues who are not as specialized as he often have trouble with. And she says, and it's a great line, which I'm going to repeat verbatim, I feel like I'm paying my doctor to educate him. So, Dr. Chaudhuri, how do we educate the medical community?
I have not taken this for granted at all. In fact, our paper on the non-recognition of Parkinson's non-motor symptoms actually angered quite a few of my colleagues because we pointed our fingers squarely at them. I think it's really... it's a question of propagating the message through talks like this, making non-motor symptoms a high-profile research priority for funding bodies, which will allow scientists to come in and publish more papers. And really, at the end of the day, it's the evidence base which clinicians cannot ignore. So the more we have people with Parkinson's wanting management of their non-motor symptoms in the clinic, the more the clinicians will be likely to start listening to them and look at treatment options. However much we do, it's not half as powerful as the voice of the people with Parkinson's. That would be my approach.
Right.
To go through people with Parkinson's.
Well, it's a great thought on which to end, and really we're just awfully grateful to you. I have a few public service announcements, if the rest of you would kindly stay on the line for the appointed extra 10 minutes. First of all, I want to thank once more our sponsors for the whole session, AbbVie, the company that used to be known as Abbott Pharmaceuticals, Teva Neuroscience, and UCB. We're very grateful to those companies for the support of this program. We'd all like you to know that an archive of today's event, as most of you regulars, and there are a lot of regulars on this call, I know, will be available for you to hear starting next week, Tuesday, March 19, at the PDF website, which is www.pdf.org. We're going to send you an email. We know what your email address is if you're on this call, and when it's available so you can listen to the talk again or let your friends know about it. Which, given the quality of the talk, I'm sure many of you will want to do that. For those of you who are seeking continuing education units or credits, we'll send you an email this afternoon with a link to take the required test. I guess we know who you are. Is that right, Eli? And we'll be sending you an email later on this afternoon Eastern Time, United States Eastern Time. And we'd like to, again, part of our public service advertising, to alert you to the next talk in this series, which will be the 5th of 6 in this year, which will be on the subject of the always important and popular subject of what's in the Parkinson's research pipeline that we can expect perhaps to see on the drugstore shelves soon thereafter, or we certainly hope we would, though often that doesn't happen for reasons I'm sure we'll be hearing then. Dr. Kapil Sethi will be our speaker. He's from the Georgia Health Science System, and the date will be Tuesday, April 16, from 1 p.m. Eastern Time, United States, to 2 p.m. Eastern Time, United States. We always do these Tuesdays at that time, so to minimize misunderstandings or miscommunications. And finally, I want to remind you, it's awfully helpful to us, so please, please, please do this. Complete our online survey. It should be on your screen right now. Your feedback, of course, helps us to improve the webinars, make them relevant, and ensure that you get the information that you need. We had a question about biofeedback earlier, and when it comes to content feedback, PDF takes this very, very seriously and does build its programs around the kinds of responses we get to these sessions. So once again, Dr. Chaudhuri, thank you very, very much for this terrific talk. I was so excited about it myself, I dashed over in the middle of the session to the editor of our newsletter, our very able young Melissa Barry, and got a tentative yes from her when I said, could we do a newsletter article on the subject quite soon, because I think it's something everybody clearly is very interested in. And so we will be working on that, and we'll let you know later when that's around so that you can catch up in through another format. Sure. Dr. Chaudhuri, thank you again. Enjoy your evening and your week. All the rest of us and you and among our audience, tune in next time, we hope, and keep the questions coming. As you know, you can always give us a call on our 800 line, 457-6676. That's an 800 area code if you're in the United States. If you're not, call a regular number and we'll tell you how to do the other. And do join us again for the 5th in the series. And thanks to our wonderful speaker. I wish you could hear their applause. Unfortunately, our technology is not set up for applause, but if it were, it would be deafening. Thank you, Dr. Chaudhuri, and thank you, everybody.